right,
Shelley.
Dr. Bradley, I've hit the recording button.
Okay.
I see Dr. Tang is on the call as well.
Yes, ma'am.
Excellent. All right, well, we will go ahead and call to order at 9:01. Just a few housekeeping issues with Google Meet. Please remember that this is recorded as part of public meeting, and so the entire meeting will be recorded, which includes the chat box as well as any audio or any camera footage as well. Please keep yourself on mute when you're not speaking. We have a few open lines right now. Shelley will do roll call in just a second. Both Shelley and Julia will monitor the chat box. So if you have any questions and are having difficulty unmuting yourself, they will help with that. And again, if you, because we're doing this 100% remotely, if you could please make sure that you identify yourself prior to speaking so we know who is speaking. I see a comment in the chat box saying, has the meeting started? I'm not hearing any audio. I will reply, yes. If anyone else is having issues with the chat box, please let us know. Otherwise, we will go ahead to roll call. Thank you, Shelley.
All right, we'll start with Andrew Tang.
Present.
All right, I'll call on next is Brent Burgett.
Present.
Thank you. Chris Salvino. Clifford Jones. David Notrica. Debbie Johnston.
Here.
Franco Castro-Marin.
Here.
Gail Bradley. Garth
Present.
Gamer.
Present.
Herman Butler advised that he would not be able to attend this morning. Iman Faiserfan.
Present.
Jeff Farkas.
Here.
Judy Baum. I heard you earlier. Melissa Anderson.
Good morning.
Neil Williamson. Neil. Looks like next is Narav Patel.
Shelley, this is Vicky. Dr. Patel just got out of the OR. He'll be on in 5 minutes.
Oh, thank you. Philip Johnson. Rodney Reed.
Here.
Sandy Nygaard.
Here.
Sharon McDonough.
I'm here.
Sean Bowker.
Present.
Tara Johnson. And Vicki Bennett.
Present.
Count 17, and we do have quorum.
Excellent. Thank you very much, Shelley. If you, for some reason, could join the meeting late or are finding that you weren't recorded, please send Shelley an email. We'll make sure that your attendance is recorded for the meeting as well. Thank you, everyone, for, again, attending a virtual meeting. We have a great attendance so far. It looks like we have 55 attendees. So thank you, everyone, for joining. The attendance report is attached in the packet that went out to everyone. We have 3 individuals who are recently renewed. So welcome back with your renewal for Brent, Rod, and Sean. So thank you guys for all your continued participation in the committee. In regards to vacancy, we still have a vacancy from a representative from a federal Indian Health Services organization. Upcoming vacancies that will be coming, Tara Johnson advised her hospital's changing designations, and so her term will expire at the end of the month. And this is for a representative from an urban advanced life support-based hospital that is not a trauma center. So I know as we get more level 3 and 4s, this is sometimes a little harder to fill, but that will be an open position coming up. I'm going to pass it off quickly to Julia to speak about a request for naloxone. Julia?
Yes, good morning, everybody. I just wanted to quickly remind everybody that through the FR Care grant, we do have free naloxone available, and that link is right there on the agenda. We also have a new training. It's kind of an updated expert training. It's called the Roadmap for First Response Encounters of Patients with Potential Substance Use Disorders. That's also available on the Center for Oral Health webpage, and the link is on the agenda as well.
All right, thank you very much. All right, next up is Bureau report. Unfortunately, Chief Garcia had to attend one of the pods for the vaccination that the state is running, so she is still kind of hovering between two positions and running the vaccine distribution and response for ADHS, along with the Bureau of EMS and Trauma System. So please bear with me as I read through her report for today. Some of the normal business operations she wanted to announce is that the department continues to seek stakeholder feedback on the rulemaking process for EMS air ambulance rules, which is Articles 7 and 8, along with ground ambulance, which is Articles 9 through 11. Articles 7 through 8 are being reviewed for final comments before a formal notice of proposed rulemaking is filed with the Secretary of State. And after that, there will be an additional 30-day review period for public comment before going to the Governor's Regulatory Review Council for approval. The remaining process before adoption will likely take place in summer 2021. The Article 9 work group will continue to meet on a monthly basis to provide feedback on the ground ambulance draft, and the department will seek additional stakeholder input on Articles 10 through 11. An update on scope of practice based on the feedback from the statutory committees on updating scope of practice and rule. The department is reviewing options for exempt rulemaking that will likely include filing a notice with the Secretary of State and providing an additional 30-day review period for public comment. If there's need for additional emergent updates to scope of practice, that must be implemented sooner. In some cases, the department has the ability to implement an emergency measure to amend scope of practice based on current needs, such as a recent example was for viral testing and immunizations. A plug for anyone who is not currently signed up for the Bureau's Gov Delivery. We sent out quite a bit of communication. I think over the course of COVID, we went from just over 2,000 people enrolled in that listserv to over 5,000 now. There's been several important announcements that have gone out. One was the executive order regarding Good Samaritan relating to care with COVID. This was extended through March 31st, 2021. There was also an update to the rule waivers for EMS and flexibility of CON boundaries. This was extended through March 31st as well. Emergency Measure 2020-05, which authorized all levels of EMCTs to administer COVID-19 and influenza vaccines and perform diagnostic viral testing with written approval by their administrative medical direction. And then we've updated some screening and training resources for COVID for the pre-hospital setting as well. All of those are available on our Bureau's website, but we wanted to make sure we made those announcements today. Another update is, unfortunately, we have had quite a few transitions in the Bureau of EMS and Trauma System. I'm sure everyone knows that Chief Garcia has become the new Bureau Chief, so she is being transitioning over from her other role at ADHS. Ben Fisher, who was also the services section lead, has unfortunately left. He had transitioned with his family who moved out of state to Utah, so we were very sad to see him go. And Allison Welch has also left the Bureau after, I think, over a decade, and so she has left as of December 31st. So we are in the process of putting those positions out for kind of replacement. We did have an opening for the enforcement manager position. That position was just filled, and we look forward to introducing the new enforcement manager at the next meeting. Those are the Bureau Chief reports and Bureau updates. I'm going to hand it over to Vatsal next for just a quick update on opioid and out-of-hospital cardiac arrest. Thank you, Vatsal.
Can you guys hear me?
Okay. Yes, we're going to share the.
I'm going to share my screen. Yep.
Okay.
Okay. So what you see over here are cardiac arrests over the 3 month from January to December. And if we see that that's 2018, then 19, and then 2020. And what we see for the cardiac arrest incidents is these are the raw numbers. The second graph talks about the percent of cardiac arrest, and then the third graph talks about the cardiac arrest per 100,000. So it's a rate of cardiac arrest. Volume is increased in January and February a little bit. Then March, still 2020 was a little higher. But then what we observed after that is that compared to April and May of 2018 and 19, 2020 had a very not significantly, but it is a higher volume of cardiac arrest. And it kept on going for all the months, like May, June, July. July, we see a peak in number of cases. August, then September, October, November, it's the same story, that the cardiac arrest cases were higher compared to the last year and the previous year.
Also, sorry, there's just a request from the someone to enlarge that if you're able to, the imaging.
Let me see. Do that. Yeah. Just give me, oh gosh. This is tabloid, always execute query and takes time.
I have a PDF of the image if you want me to.
Let me cancel. Yeah, this is not going to work now. It messed up. We will have to open up the PDF only.
Do you want me to display my PDF of it?
Yes, please. I will stop representing now.
Okay.
Okay, what is that?
Is that visible?
Yes, thank you.
Is that visible? Okay. All right, that's better. Yeah, so what the first graph also shows that the volume is increasing every month compared to the last year. And then the last graph, which shows cardiac arrest per 100,000, basically that takes into account maybe there is an increase in the population in 2020. Maybe that is the reason we are increasing. So we controlled for the population, and that's a rate. And we see the same story that cardiac arrest cases or the rate increased compared to the last year by month. And the graph over here, the patient death shows the dead and transported. And we just wanted to see the number of transportations increased or decreased during in 2020. And if we see the number of transports are kind of decreased, in the 2020 compared to the 2019 or 18 years. And it's true for all these months of 2020, the number of transport decreased. And obviously, because the number of transported decreased, the number of dead increased. We can go to the next one, the opioid.
I'll let you share your screen for that.
Is that?
I think the same issue of size, Shelley. It's for enlarging it.
Sorry.
Should I open it up on the PDF?
I got it.
Oh, okay. Yeah.
Is that adequate?
Right. So that's the number of opioid cases per month, again, comparing the last year and 2019 and 2020. And we did see a spike in May, June, and July. And after that, again, it went kind of, we can't say anything. It's almost similar to the previous year in the opioid cases. So here, I don't know what, I mean, we saw a spike and then it is back to, again, normal. The deaths are, we saw there is increase in deaths due to opioid almost all the months compared to the previous year. That's about it. Is there any other comments, Dr. Bradley, you want to add?
No, thank you for presenting those. I know we had some questions from stakeholders regarding specifically out-of-hospital cardiac arrest data along with opioid data. So thank you for pulling the year-over-year data for this group. Any questions for Vatsal? Vicki, it looks like you have a question.
Sure. I think what I would like to see, I don't know about other members, but, you know, with the legalization of recreational marijuana starting, I know other states have experienced a surge in traumatic injuries. I also know that this is viewed by some as a replacement for opioids, and I wondered what our plan would be for evaluating this going forward and how we can cross-reference the data to have something meaningful for us to draw some information and perhaps even publications on for our state. Are we going to be able to collect? There's a lot of variables in it, and it may be hard to track down, but I know other states, Oregon, Washington, Colorado, have published on this and have had significant impact. So I just wanted to make the comment to see if there's a consideration for future.
I think that's great feedback, Vicki. We definitely can make a note of that, especially as we're kind of just now starting with the beginning of 2021 with that going into effect. So thank you for raising that up as a research opportunity.
Hi, this is Dave. ADOT in their crash records database captures substance tested or relationship to the crash. There may be an opportunity once you guys decide how you want to work out the research strategy to collaborate with ADOT with their crash data.
Very good, thank you. So yeah, definitely great idea, Vicki. I have that down as a note for our team. Any other questions or comments for Vatsal? All right, thank you. Next, we will move to standing committee reports. First up for TEPI, Sean.
Good morning. Can everyone hear me?
Yes, thank you.
Thank you. So the TEPI committee met on November 19th. It was called to order. We had a quorum, and we were able to discuss a vacancy for the Southern Arizona EMS Council. Later in the meeting, we also discussed revision to the roster and to allow for pre-hospital EMS coordinators for each region, and that was approved as well. So there are now vacancies for EMS pre-hospital coordinators for Northern Arizona and Southern Arizona regions. We had reports from EMS for Children, and as well as Ben Fisher reported much of the same data that Vatsal just presented to us with regard to opioids and cardiac arrest. And then Dr. Bradley introduced Chief Garcia and also mentioned that she's continuing her work with the emergency operations committees for the state, as well as trying to get her feet under her for this new position. We discussed, amended, and approved TEPI meeting minutes. And then we discussed the Premier EMS Agency Program Data Standard. And a motion was made. Well, we discussed the length of time cutoff scores, go live dates, etc., for validation scores for benchmarking. And Mr. Fisher noted that the Cactus Data Completeness product was unsustainable and proposed using data validation scores for benchmark scoring moving forward. And the committee recommended using data validation scores for Premier EMS agency program status, and a starting score would be 90%. Reporting frequency will be quarterly, and the amount of time to improve before losing status will be a year, with a go live date to be determined by the EMS Council. So the motion was approved. And then the standing items, we made no changes to prioritizing the reports. They stay in the same order. And there were no significant updates from TRUG. The program manager workshop, we discussed the abbreviated injuries scale updates expected in January, and there's discussion about classes for the registrars regarding that. And then EMS registry user group, there was an update given by Mr. Proa, and then there was a call to the public with no major items discussed, and the meeting was adjourned.
Thank you. All right, next up, Sandy for Education Committee.
Yes, the Education Committee also met on November the 19th, and we also have a quorum. The Bureau report, Julia reported on EMS for Children, and she reported that the data collection surveys are coming up in 2021, and the Safe Sleep training is proposed for Education Committee approval. It was subsequently approved. Ben gave a report on the opioid and cardiac arrest data, and very much what you heard here today. Dr. Bradley thanked everyone for attending and welcomed the new Bureau Chief, Chief Garcia. And Dr. Bradley also discussed the COVID-related initial and ongoing certification issues. Discussion and action items. Excuse me, did approve our minutes for the previous meeting with no amendments. We did discuss, amend, and approve the bylaws. They were and updated roster rules. We approved updates to medical decision-making capacity training. We also, the training was approved as it was amended. We did, as I said before, approve the Safe Sleep PowerPoint toolkit, and that was also approved. And in our standing items, we reviewed posted training modules table. And Dr. Rice went through the list and noted that the VAB training was due for review, and she did ask for volunteers for that review. Dr. Bradley also asked a request to create a training curriculum for EMS immunization administration with a timeline prior to year's end. And our next meeting is March the 18th. Thank you. Any questions?
Thank you, Sandy.
Thank you.
Next up, PMD, Franco.
Good morning. Is audio okay?
Yes, thank you.
All right, so we met when had quorum at our last meeting, which was November 19th. We had a review of EMS for Children update from Ms. Vinton. We reviewed the opioid and cardiac arrest data as we did just now this morning. We had our regulatory and bureau chief update, including welcoming our new bureau chief, Rachel Garcia. As far as action items are concerned, we discussed, amended, and approved an updated Table 5.1 Arizona Scope of Practice, and that will be coming to EMS Council and MDC, I believe, this morning. We discussed and amended and approved bylaws, including an updated roster role for PMD. We were adding one member for a total of 14 members, and that member will be a representative from toxicology. We discussed, amended, and approved Table 1, the drug box, by adding an inhaled anticholinergic to the EMT level, and that motion did pass. That will be going to MDC, I believe, this morning for final approval. And then we also made another drug box addition with oral over-the-counter analgesics for pain and fever to all EMCT levels. That motion was also approved and is awaiting approval by MDC this morning. Thank you.
Thank you, Franco. Next up, Kara for Trauma Managers Work Group.
Good morning, everyone. We had our last meeting a couple months ago, but we have our next meeting coming up next Friday, January 29th. Open items from our previous meeting was discussion of the AIS training, and we worked with the Arizona Trauma Association to help support programs that needed educational courses to get that training. So we offered, I'm not sure how many centers took on the offer from the Arizona Trauma Association, but we'll have an update from them at our next meeting on how many trauma centers took on that education help. At our next meeting, we will be discussing the American College of Surgeons alterations of site visit practices and how it's going to affect some of our verified trauma centers from the state's perspective. We will have an open discussion that will include discussion about COVID-19 mitigation and how other centers are making changes to their injury prevention activities to still meet state requirements.
Thank you very much, Kara. Next up, Julia for PACES update.
Good morning. As was already mentioned at our last PACES meeting, we did approve the safe sleep training. So that's currently posted on the ADH webpage for youth. We also have an ongoing work group for children and youth with special healthcare needs. Our next scheduled meeting will be on February 8th. Lastly, we are in the midst of some national EMS data collection this year. So currently we are conducting the EMS survey. So we've had 45 respondents thus far. So thank you so much if you've already participated in that. I encourage you to continue promoting that as possible. We also will be soon starting the National Pediatric Readiness Assessment, which will be a similar assessment but of hospitals. So that will start in May. So materials for that will be distributed in the near future. End of report.
Thank you, Julia. Next up for discussion and action items, if we can get a motion to discuss, amend, and approve the staff meeting minutes from September 17th.
So moved.
Thank you. Is that you, Dr. Gamer? Okay, thank you. Can we get a second, please?
Seconded. This is Debbie.
Thank you, Debbie. Just quickly scroll through those. Hopefully everyone had a chance to review those ahead of time. Are there any amendments or recommended changes to the minutes? All right, in the interest of trying to do a more efficient vote, we will say, is there any opposed to the meeting minutes as posted? Please speak up now. All right, all those in favor, please say aye.
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 All right,
Aye.
thank you. Meeting minutes are approved. Next up, we have need to get a motion to discuss, amend, and approve creation of a work group for pre-hospital blood products.
So moved.
Thank you,
Gamer.
Dr. Gamer. Can we get a second, please?
Second.
So we need a name for the second. I heard a couple people speak up there.
Sean Bowker.
Thank you, Sean.
Do I want to keep it? Yeah, do you want to keep it for your files?
Garth, you're not muted right now.
Oh.
Thank you. So a couple things just to give a little bit of background. This question has come up to the Bureau in a number of different avenues and kind of questions regarding when and how can EMS potentially administer blood products in the pre-hospital setting. We've done a little bit of background work, and I'll give a quick brief summary. I know that there was some interest that came out of, I believe, the Trauma Managers Work Group, and so I do have 6 names that we'll list off that volunteered from that group that would like to participate, and then we'll see who else would like to participate in that committee. Currently in Arizona, kind of an easy way to think about who can administer blood products or who cannot. If you have a 911 call and a paramedic response, it is not in the drug box, so they cannot administer blood products. If you have a 911 response and a nurse response, it is allowed as part of nursing scope of practice. We confirmed that with the nursing board, so it would be allowed for nurses to administer on a 911 call. If you have an interfacility call and a paramedic, blood products are approved on table 3 if trained. So this is your interfacility drug box. So for an interfacility transfer, paramedics on those types of calls, if trained, could monitor blood as it was infusing. And if interfacility and a nurse response, again, this is within their scope of practice. So that's just kind of a brief summary of that. So I wanted to kind of give that little bit of background. I'll open it up to the group, and then we'll definitely take volunteers, and I'll list the 6 names that we have so far as well. Is there any questions or comments for those who've been interested in this topic? I know it's come up in multiple settings.
I would like to volunteer for any subcommittee that you put together.
Okay, thank you, Dr. Gamer.
Hey, Gail, it's Nurse Patel. Happy to do the same.
Thank you.
Dr. Bradley, it's Vicki. I'll as well participate.
Thank you, Vicki. Any other discussion or input that the group would like to provide? I know this has come up in a few different settings, so I wanted to kind of at least just put out there what the current scope of practice and drug tables look like in Arizona, just so that everyone had that background. Anyone else interested that participating or has comments?
Dr. Bradley, this is Sean Bowker, and I'm volunteering.
Thank you, Sean.
Good morning. This is Sharon McDonough, Tucson Fire. I'd also like to participate.
Thank you, Sharon. And I see Dr. Dabrowski. Yes, you can absolutely participate as well.
Hey, Gail. Andy Tang here. Volunteer.
Yes. Thanks, Andy. And Kara Mitchell as well. All right, the names that we had from previous that had expressed interest that we do have down include Brooke Reeves, Jody Allen, Joyce Hospodar, Lori Danko, Jill Bullock, and Kimberly A.R.S. So those were the 6 names we had previously. In addition, that have volunteered right now, I have Dr. Gamer, Dr. Patel, Vicki Bennett, Sean Roker, Sharon McDonough, Dr. Dabrowski, Dr. Tang, and Kara Mitchell. Is there anyone else that would like to participate in that work group?
Dr. Bradley, it's Vicki. Is there a way to make sure we have wide representation from all key stakeholders? So we have a great group assembled, but I want to make sure that we have representation from the key stakeholders, whether that be flight or whoever.
Absolutely. I believe based on the names, I think we do have some flight representation from the 6 names that were forwarded before. So definitely, I know this has come up. I think this originally came from the trauma managers work group
Yes.
with some of the flight companies as well. So absolutely. When we do form the work group, we always like to try to not let it get too large, but we do want to encourage participation so we can make sure that that gets publicized as well. I see Ben Perry with Guardian Air. We have Ben down. Thank you. Nicola?
Hi, Gail. I would definitely like to have somebody from Air Methods be on that committee.
Do you want us to put your name down for now?
Yeah, put my name down for now until I can get a better clinical person.
Okay, perfect. We'll do.
Thank you.
All right. All right. Well, thank you, everyone. Yes, so thank you for all the participation. So we have, I think, a good number of names there. We will make sure that we capture all of that. So I just need to officially get we've got the motion on the table with the second. Again, I'll take the any opposed first, just so that's an easier way. Is there anyone opposed to the formation of a work group to evaluate pre-hospital blood products? Okay, hearing none. All those in favor, please say aye.
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 All right.
Aye.
Motion. Thank you. Motion passes. All right. Next up on the agenda, we have tried to add some topics to STAB. One of my goals as I took over as the medical director for the Bureau, was to really try to increase kind of participation in this committee, and then also hopefully come up with some topics which would be interesting. The group's suggestion at the last meeting was to have a research presentation related to EMS and trauma. Today, we're going to have the kickoff presentation from Dr. Spate regarding the EPIC TBI project and some of the updates regarding that. We will need a topic for the next meeting, so if anyone is interested, please be sure to forward that to myself or Shelley, and we'll get a topic on the agenda. But we're really excited to kind of start having a specific EMS/trauma presentation at these meetings. Again, hopefully to highlight a 5 to 10 minute presentation at each meeting as we move forward. So thank you for the group for supporting this, and I will turn it over to Dr. Spate.
Well, thank you, Gail, and thanks for the opportunity. Let me, Shelley, thanks for unpresenting, and let me see if I can get this up. So a window, there we go. There. Okay, do we have a successful launch there?
Yes, sir.
Okay, great. All right, well, thanks again for the high honors, excuse me. It would help to start at the beginning rather than at the end. For the high honor of presenting to STAB, and something that's been near and dear to the hearts of many, if not all, involved in trauma in Arizona, the EPIC EMS traumatic brain injury study, and on behalf of the incredible EMS agencies and the Department of Health Services and University of Arizona, the great partners in EPIC, I'm really grateful. This is an update since the publication of the main study in JAMA last year, and then just a few months ago, the EPIC for Kids study, and then some really fascinating new and surprising findings as we have a large DoD grant now that we're unpacking some of the a priori sub analyses and some really amazing stuff coming up. Just so everyone has a baseline of what we did. We implemented in more than 130 EMS agencies in Arizona that ended up representing over 93% of all major traumatic brain injury that were taken to trauma centers ultimately within the state of Arizona. So it truly was absolutely statewide. There were 5 super trainers led by Bruce Barnhart at the U of A who trained more than 600 master trainers, really a mind-boggling implementation. Ended up training more than 11,000 EMS providers. And as you can see, the total study had nearly 22,000 patients, TBI patients, over an 8.5-year period. It was a before-after system trial, with the last 3 years being, on average, typically the post-implementation period for the typical agency. There were 4,000 intubated patients. And the beauty of the 82 pages of the EMS traumatic brain injury guidelines is you can boil 82 pages all the way down to 3 things. And this is what EPIC was. It was the implementation statewide of aggressive prevention and treatment of hypoxemia, hypotension, and hyperventilation. That's really hyperventilation, overventilation, because obviously both can cause hypocapnia, which is horrendous for the brain, injured brain. And that's the real focus. And I'll jump right to it because we don't have a lot of time today. This is the we did it across very broad, moderate, severe, and critical TBI. So AIS 1, 2, AS head region 1s and 2s, moderate, 3s and 4s severe, and 5s and 6s critical. And as you can see, the severe group was 3/4 of the study, that is, and we had a priori reasons to believe that we were unlikely to alter survival in the 1s and 2s because in Arizona, way more than 99% of those patients live in our trauma system already, even as it was. And we had reason to believe that it might be more difficult for prevention of secondary injury to markedly impact survival in the 5s and 6s because they tend to have such severe and critical primary brain injury that often they're at very high risk for death, even if you do perfect management. And certainly we at the trauma centers all understand that lots of brain injuries are just so severe that even when we provide perfect care, unfortunately, they have bad outcomes. So this is the sweet spot group, and amazingly enough, as you can see, for those who don't think in forest plot, the unity line here of 1, right, means that in the before-after comparison, if you have a point estimate, which is the square, and the whiskers, which are the 95% confidence intervals, if this entire whisker plot is to the right of 1, it means there was a positive outcome on adjusted survival. Obviously, we do adjustment because the age was different, severity was different, obviously. So doing logistic regression allows you to compare apples to apples by adjusting afterward. And amazingly enough, as most of you probably know at this point, implementation was associated with an adjusted odds of survival improvement, basically doubling. And you can see the p-value here is way less than 0.001. And then in the intubated, an important a priori subcohort, the intubated severe group. So again, remember, this is all the patients in EPIC that had AIS heads of 3 and 4. The 1s and 2s and 5s and 6s, as we suspected a priori, actually did not show a significant improvement. But this very large severe group, 3/4 of the study, showed a tripling of adjusted odds of survival in the intubated severe group. And here's, we just published this a few months ago in Annals of Emergency Medicine. And as you can see, really amazing. This is under age 21, which is what the NIH, original NIH funding definition was. And so that's what we kept for our official reporting until the paper published a couple months ago, which is actually focused primarily on under 18. But as you can see, the AOR of 5, really quite amazing. And in children who had positive pressure ventilation, so this would be either bag valve mask and or supraglottic airway and or intubation, you can see this remarkable 7.5 adjusted odds of survival. Really striking findings. And so just to run through a few of the implications and some of the new and really cool findings, it's really important to understand that when you're looking at these airway groups, that we did not compare basic to advanced, right? This was comparing the within airway category groups basically before and after doing ventilation correctly, right? The incredible focus, meticulous post-procedure prevention of hyper and overventilation using Untitled CO2 and flow-controlled bags and visual cue ventilation rate timers with the proper either adult or pediatric ventilation rate, all of those things. And this is the money slide here for understanding what we found in the this is all ages. And notice here, among patients who had positive pressure ventilation and a severe TBI before statewide implementation versus the same group, all positive pressure ventilation after, there was an adjusted odds of 3.5 improvement in survival. This is just an astounding number. But remember, this is not comparing basic versus, this is not comparing airway to airway. This is comparing everyone who got positive active ventilation before to everyone who got active ventilation after, and just those impacts had this kind of an effect. This was advanced airway, so this would be supraglottic and endotracheal intubation, and you can see it's an odds ratio of 3, adjusted odds of 3. And this was the endotracheal intubation group alone, and again, the severe group. And again, you see this adjusted odds of 3 when comparing endotracheal intubation before versus endotracheal intubation after. So again, this is comparing a procedure to itself afterward, showing what seems to be, we can't prove obviously because it was not randomized, but seems to be profound impact of both the improvement in hypoxia and the decreasing the people who are experiencing hypocapnia. And so this shows the importance of proper ventilation, regardless of which airway type is used. Really striking findings. Interestingly enough, probably most of you know that the The guidelines were primarily developed with a focus on isolated traumatic brain injury, because multi-system TBI is just that. It's a very complex mosaic of all kinds of different injuries. Some in multi-system TBI, there weren't a lot, and essentially none of the studies in either animals or humans supported permissive hypotension in patients with substantial traumatic brain injury. But there are some who have even clung on to that, so concerned about the issues related to giving aggressive fluids in potentially bleeding patients. So these, what we found was, not surprisingly, in multi-system TBI, those patients were 4 times more likely to be hypotensive. Obviously, a patient who has a big intra-abdominal injury and a TBI compared to a person who has the identical TBI but no intra-abdominal injury is more likely to bleed and become hypotensive. The MTBI group were twice as likely to get fluid boluses. So interestingly enough, this is really striking. And remember, we were not powered nor designed to compare the effectiveness in isolated versus multi-system TBI. But notice here, this group, these are the forest plots for the isolated TBI. And as you can see, among all ages, a highly significant 60% in adjusted odds of survival in isolated TBI after implementation, and strikingly, 2.5 adjusted odds in all-age severe multi-system TBI. This is really a surprise. So the way to say it, don't hear what I'm not saying. Again, we're not saying that the impact was greater in multi-system than in isolated TBI, but it is statistically accurate to say that it appears that implementation of the EMS guidelines in the field is at least as effective in multi-system traumatic brain injury as it is in isolated traumatic brain injury. Really surprising and fascinating finding. Air and ground, again, we were not designed nor powered to compare air versus ground, so don't misinterpret this. But if you just look at the air here, start with the ground here. So severe ground, 1.7. So ground only transported patients improved by an adjusted odds of 70%, and tripled in the intubated ground transported intubated patients. And here you can see air transport 3, and for the intubated severe, almost 5. And one of the things that's fascinating about this, and one of the we are going to be doing a national multi-system EPIC 2 study is deep in the planning with the NIH now. Interestingly enough, one question comes up here is remember, the air transported patients they benefited both from the air personnel being trained, as well as the ground personnel that called the air personnel being trained. So one wonders that if there is a trend toward this group doing better, which it is not statistically, and again, we're not designed to say, it is interesting that maybe this is in essence a double dose of EPIC, if you will, that before neither air nor ground in these patients were trained. Now they are and providing guideline care. And here you had both air and ground trained and providing guideline care. So really fascinating finding. And then I think we're getting close to the last, because I know we don't have much time and time is short. Notice you just don't see this in biology. So I want to make sure, or you so rarely do, I want to make sure we all understand. Here is the all EPIC study, right, of the severe cases. So this is about 15,000 cases in the pre-post analysis of the severe TBI, AIS head of 3 and 4, all comers, right? Air, ground, multi-system, isolated, everyone all together across all ages. And as we saw in the main study publication, a doubling of adjusted odds of survival in the severe cohort. Then that's all age. So notice, this is really amazing. If you then take the patients who are 75 years of age and older out of the cohort, notice the trend as you go through removing the 5-year elders at each point, notice with me how there is at every single point, and again, we're not powered to compare the ages, so we're not saying that it was better in children than adults. We can't prove that, but notice every single point estimate, and you can see the actual point estimate here, when you go to a younger and younger and younger cohort, every single one moves to improved apparent adjusted effectiveness. So this is a really fascinating finding with amazing, to me, implications for, say, trauma triage. Because, you know, we've chosen, as you know, I'm old enough to remember the days where it was over age 50 was a risk for one of the things that helped decide to go to a trauma center. And then it went to 55, and then it started at 65, and it moved down now either to 55 or 50, depending upon who you talk to. But what is interesting is, should we be surprised, for brain injury, it's always better to be younger. And this is the best evidence I have found yet on the clinical side for the concept of plasticity, that there may be, in fact, a true reality to the younger brain's ability to bounce back with proper treatment. Really an amazing finding. And then the last finding that I'll present today, and then if it's up to Gail, I don't know if we have time for questions or not, but happy to take them if we do have time. The association between the intervention and improved outcome was very strong for the first 18 months after initial training, but then it began to fade. So just so everybody understands, the average agency was in, we had 4.5 to 5 years of pre-implementation data. And then there was typically a 2 to 4 month run-in period where the training was being done, which obviously that was excluded from either phase because you had mixed treatment then. And then the typical agency had 3 years in the post-intervention time. But it really started to fade after the first half of the post-intervention phase. And we don't know why for sure, of course, but one obvious potential reason is we had control of initial training and certification, but we didn't have control of retraining. So we did offer all kinds of different short, long, intermediate length virtual experiences for refresher training and so forth, but it was a great mosaic, and some probably didn't do anything except the initial training, unfortunately. And so it's possible that the lack of constant vigilance leads to distraction and a return to old habits. And I want you to look at these numbers. These are really striking. Remember that the overall study in the severe was an adjusted odds of 2. And amazingly enough, look at this. For the last 18 months, that was 1.7, still highly statistically significant. But in the first 18 months after implementation, it was 2.5. Sorry, this keeps jumping. So this is even more striking in the head injury severe, right, 3s and 4s that were intubated. Notice a 1.5 to 3 years after implementation, it was still very consequential findings of improvement, 2.5. But basically, the second 18 months lost half of the apparent effectiveness that occurred during the first 18 months. And so one of the things that's a phenomenal, there's 2 phenomenal implications here. It is truly astounding to think that even after a 1.5 post initial implementation, there were still highly significant differences. So the resiliency of the combined implementation seems to be real and remarkably powerful, given that we did not have a mandated or forced refresher. But this is really striking to remember. By the way, coincidentally, what we got in between this time was, unfortunately, loss of some of the improved outcome in head injury, but we got a really effective Ebola preparedness system. Right, so we spent a bunch of money on Ebola, but it looks like the system gets distracted, really telling not just about TBI, but probably about EMS interventions in general. And you know what, I think I'll just bag the summary so that so I don't go longer than I should. And then also, if there's time for questions, Gail, I'd be happy to take them. That's up to you.
Thank you very much for that summary, Dan. We probably do have time for a couple questions. If there's anyone that has any questions for Dr. Spade, thank you for that wonderful summary.
Dr. Spade, this is Dr. Castro-Marin. Just one brief question. What's the implication of the confidence intervals being so broad on the pediatric data? Thank you.
Great question. One of the things that the overall answer is saying that the confidence intervals are wide in a pediatric study, interventional study, is a redundant statement, right? Because it was only 15% of the EPIC study that were under the age of 21. So even though we had a gigantic, nearly 4,000 cases in pediatrics, and in the sweet spot group of the severe head injury, AIS 3s and 4s, we had nearly 2,800 cases. So that's a very, very large pediatric traumatic brain injury study. It may be the largest in history in EMS, as far as we know. But the bottom line is the numbers are always smaller. But what is, to me, that's one of the reasons why that slide that shows as you march down to younger and younger and younger ages, that the adjusted odds of improvement in survival gets better and better and better. You don't have to be a biostatistician to look at that and say that I'm not too concerned about the statistics, because even though the confidence intervals are getting wider and wider and wider as you get down lower, obviously because the group is smaller as you get to lower and lower ages, that the point estimate ever improving, getting better and better all the way down to the pediatric age range is almost for sure real, and it is certainly biologically plausible. So it appears to me that the implications are that whether the actual adjusted odds is really 7.5 in children, or it's only, quote, 3.5, it's still an amazing finding. And it appears that there are such dramatic improvements in the young brain when we don't let them be hypotensive, don't let them be hypoxic, and prevent ourselves from creating hypocapnia.
Thank you. We probably have time for one more question if there's another one. All right. Well, thank you again. We really appreciate your presentation today. Like I said, this is kind of an exciting, I think, addition to this STAB meeting. Looking forward to sharing some of the wonderful research being done on EMS and trauma throughout Arizona. So thank you for kicking off this part of our agenda. So thank you again, Dan.
Thanks, Gail. See you at EMS Council.
Sounds good. All right. Next up on the agenda is just a presentation from Dr. Patel from the American College of Surgeons Committee on Trauma. Dr. Patel?
Hey, this is Andy Tang. Dr. Patel has asked me to speak on his behalf in presenting the information. So several things. Number one is in regards to verification of trauma centers. The manual that all trauma centers rely on for standards and expectations for our verification is called the Optimum Resource Document. The most recent version is 2014. That's when it was first printed. There is ongoing, there's a new edition coming out in 2021 in the spring of this year. And the new updates and standards will be anticipated to be in effect 1 year after the following the initial launch. And again, we expect that to come out sometimes in the spring of this year. In regards to verification visits, due to COVID and the diverted resources and attention starting in 2020, many of the trauma centers who are up for verification or re-verification had to be postponed. And most of these centers received a 12-month grace period. So right now, those centers are beginning to be scheduled for virtual visits, which is something new. In the past, it was a 2-day visit by the American College of Surgeons inspectors, on-site visit. And again, because of the impact of COVID, this new virtual visit is being created, and centers are being scheduled somewhere between March and June of the centers who are up for re-verification between March and June of 2020 are now being scheduled for this year. In regards to education, we're on the ATLS 10th edition right now. Again, due to the impact of COVID, we have, in addition to the traditional ATLS, which is a 2-day course, consists of didactics, practicals, discussions, and an exam, both written and in person. That format has been somewhat altered. We now have the addition of ATLS, which is a virtual component where there are 14 modules that can be taken online and at the learner's own speed, after which they have to present for a skill station sessions and testing. And so these are some of the modification to the traditional ATLS format. In regards to provider expirations, and again, it's all secondary to COVID. A lot of ATLS courses were suspended due to the need for social distancing and the lack of any alternative format such as the MATLS. So as a result, many providers who were about to expire in 2020 had an extension of 1 year. And the providers who are expiring this calendar year of 2021 are eligible for a 1-year extension if they complete a mandatory content review. And that is a 14 scenario-based questions that you can take on the ATLS website. After completion of that, you will get immediate feedback on whether you passed or not. And when someone achieves 100% score, then they can be granted the extension of 1 year. And that's for folks who are about to expire in this calendar year. In regards to the ATLS instructor course, there are pilot programs for a hybrid course. And again, before it was, another 2-day course in person, where we have a instructor who teaches potential ATLS instructors how to teach the course. Very much focused on the art of teaching rather than the content of management. Again, because of social distancing needs, now there are hybrid pilots that are being tested. ATCN, which traditionally had been conducted in conjunction with ATLS because some of the contents overlap, and the nurses and physicians can take the course together for parts of it, and then they separate into their individual sessions. So right now, the ATLS leadership is working collaboratively with ATCN leadership to launch a hybrid option as well. Rural trauma training development course. Unfortunately, there are no virtual options at this time. I'm sure that's something that the office is working on. We have other courses such as BEST, ATOM, ASSET, and TEAM. And some of these are really procedurally based courses for surgeons, advanced trauma, operative management. ASSET is the advanced surgical skills for the exposure in trauma. So these are more geared towards the surgical management of trauma cases. All these courses are currently undergoing updates, and no particular instructions yet on if any virtual options would be made available. I suspect they will be. And also Stop the Bleed. There's talks of some sort of a hybrid form that can be formed, but no specifics yet. End of the updates.
Thank you very much, Andy. Any questions for Andy about those updates? All right, excellent. Next up on the agenda, we just wanted to bring back up the survey of other topics that we had received. We have added 2 to the agenda this time around. So we've got the report that Dr. Tang just gave, as well as the research update. We are going to be starting the kind of blood product work group, so that will be a subgroup moving forward. And I know the group voted last time to have a military update, so that would be kind of an additional update as we get some information from them. So we just wanted to kind of bring this back up to the group, see if there's anything people were very interested in adding to the agenda. All right, hearing none, we will just open up. We wanted to make sure we gave an opportunity to discuss COVID-19 surge concerns. I know that there has been obviously an effect on the entire healthcare system with the COVID surges. Trauma was definitely affected, especially in the spring. We saw a significant reduction in trauma numbers, I think, across the state. But just wanted to open up and give everyone an opportunity to just voice any concerns or questions they have in regards to trauma. All right, hearing no COVID concerns. Okay, we will just, Shelley, if you can maybe click on the link regarding the Gov Delivery. Again, if anyone is not signed up for our Gov Delivery, you can contact Shelley. She can tell you how to sign up. We unfortunately are not allowed to sign people up directly to any of the Bureau email listservs any longer. So if you are interested in receiving emails from us, please contact Shelley. She can tell you how to sign up. We really use this sparingly. I promise we will not spam you with emails. But if you are interested in getting updates, this is where you would get the updates for that. Next on the agenda is items to be considered for the next meeting. I saw a comment in the chat box, and I just wanted to clarify from Dr. Dabrowski and Dr. Castro-Marin. Are you referring to whole blood in regards to the blood product work group or a trauma presentation? Can you clarify that?
Presentation, Gail.
Okay, perfect. Are you volunteering to do that, Paul?
I was going to volunteer Dr. Patel, who volunteered Dr. Tang, but yes, I'd be more than happy to.
Excellent. All right. It sounds like we have a topic then for the May agenda, so we will keep you on that for May. So thank you very much for doing that.
Thank you.
All right. Any other agenda items for the next meeting? All right. Call to the public. All right. And summary of current events are attached, so you can see those there. Our next meeting will be May 20th at 9 a.m., likely a virtual one unless something changes significantly. Any other comments before we adjourn? All right, can I get a motion to adjourn, please?
Motion made, Brent Burdett.
Thank you, Brent.
Second,
all right. Thank you, Rod. All right, meeting is adjourned. Thank you, everyone. I appreciate it.
Thank you.
Thank you, everybody.